Hi, my name is Michael Ritchie, and we're going to be talking about understanding fluids. So we're going to talk about fluid physiology, fluid resuscitation and shock, non-resuscitative fluids, and then fluid overload and the complications of fluid overload. So first we're going to talk about the fluid body compartment. So we have our total body water, and then it's broken down into extracellular and intracellular. 2/3 of our total body water is intracellular, leaving 1/3 extracellular. And that's mainly what we're dealing with when we're talking about resuscitative fluids and giving fluids to patients, is dealing with the extracellular fluid. That extracellular is broken down again into about 80% is probably interstitial, leaving about 20% intravascular of that extracellular fluid. So you're really not talking about a lot of fluid compared to total body water. Whenever you're talking about fluid, you have to understand 3 different things that are helping with that push and pull. You have some things that are wanting to pull the fluid into an area, and the other one's trying to push out of that area. So osmolarity, hydrostatic pressure, and oncotic pressure are the 3 things to really understand when dealing with fluids. The first equation I'm going to talk about is Starling equation. There's been some areas that says that this isn't quite as accurate as we thought that it was, but the overall thought process was that we would kind of push some fluid out of the intravascular space into the interstitial space, and then it would get kind of reabsorbed post-capillary, and so it would be this kind of push-pull type of a thing. And it really broke down into 2 things. So it broke down into what their oncotic pressure was, and what's going to bring it in, and what their hydrostatic pressure was. So if you look, there's just a lot of things that can go into it, but basically it's just the push and pull. So your oncotic pressure will pull the fluid into the intravascular space, and the hydrostatic pressure will push it out of the intravascular space. Here's a picture to kind of go through that whole thing. Intravascularly, we have oncotic pressure. There's not a lot of proteins in the interstitial space, so there's not a lot of oncotic pressure. So the real oncotic pressure is typically just intravascular. And then both sides do have hydrostatic pressure, and that's kind of pushing against the walls, wanting to push the fluid out. And so you have that both on the intravascular and interstitial side. Hydrostatic pressure, you can think about it as kind of this force that the more you have, the more it's going to push. If you can look at these columns with water, if you don't have that column filled completely up, you're not going to get as big of a flow as if you have it completely filled up. So if you think about somebody like a heart failure patient that has a lot of intravascular fluid, they're going to have a high hydrostatic pressure, and that's why you get things like pulmonary edema. Oncotic pressure are those proteins that are going to help kind of bring all that fluid in, want it to stay intravascular. 75% of your oncotic pressure is made of albumin. That's why we look at albumin a lot when we're dealing with fluids. For every gram of albumin, it's negatively charged. And so that's what we really look at. And we know that it's negatively charged from calcium attaching to it, and we always correct for calcium whenever we do the things with it. But it does make up 75% of our oncotic pressure. We assume with that protein, with mainly being the albumin, that we would get a calculated pressure of about 20 millimeters of mercury. We actually get a much bigger pressure, closer to 30 millimeters of mercury, which would be a 50% increase. And the reason for that is what's called the Gibbs-Donan effect. And like I talked about before, with the albumin being negatively charged, it will pull over some cations, so like sodium and calcium and potassium, and it'll make the molecule bigger than what it actually is, because it's attracting those cations. And so by having that bigger molecule, it'll actually have a higher measured pressure, and that'll actually bring in more fluid. So you can tell by the illustration here is that you have slightly more fluid in the intravascular space compared to the interstitial space, as well as a slight difference between your osmolarity, between your sodium and your chloride levels as well. And that's just because of the negative charge of that albumin, and because it makes up such a large percentage of your oncotic pressure. Once that protein, or once that oncotic pressure drops, you'll lose that effect and you'll start third spacing. Typically, they say it's around 11 millimeters of mercury, which would be around 2 grams per deciliter of albumin. So once your patient's albumin gets 2.5 or below, you're going to start spontaneously third spacing. So if you're trying to keep fluid intravascular, it's going to be even more difficult in someone that also has a low oncotic pressure. So whenever you're thinking about resuscitating somebody, resuscitating a cirrhotic patient, which typically have low albumin, or resuscitating a septic shock patient who has is going to be vasodilated, but with a lot of fluid can actually get their albumin dropped down pretty low, is that once you get it down below 2.5, you're going to start having a lot of this third spacing, and you're going to lose the benefit of that Gibbs-Donan effect from that albumin. If you look at the difference between the intravascular and interstitial layer, you'll see because the albumin kind of pulled in that extra sodium, pulled in a little bit of extra potassium, as it draws it in, then you'll see that increase of sodium on the intravascular versus the interstitial, and you'll see the drop of the chloride versus the interstitial level. So like I said, based on the Starling equation, you have this oncotic pressure that wants you to pull fluid into the intravascular space, and you have the hydrostatic pressures that want to kind of push it out of their respective spaces, the intravascular and the interstitial. Where does osmotic pressure come in? So that really is the thought that says, okay, osmolarity obviously is going to make a difference. Because it diffuses across so easily, it actually doesn't participate in being able to kind of keep fluid intravascular. And that's just because it will equilibrate so quickly. You can manipulate it. And so that's where you can change the concentration and you can do something with it. And that's where you see where we're using like hypertonic fluid. So if you give a hypertonic fluid for that time period, it will have a higher osmolarity. In the intravascular space, it will draw in that interstitial fluid. And we see that being used in high intracranial pressures and different disease processes. But that's specifically where it would be changed by the practitioner as opposed to the patient having any changes in osmolarity that would help with it. And so the idea of the osmotic pressure is it's just going to go from an area of higher to lower. So it will usually you would have this semi-permeable membrane, which is what they're talking about here in the example. Like I said before, it just doesn't occur between the intravascular and interstitial space. They'll just diffuse across. But if you do add hypertonic fluids, it will pull that fluid from the interstitium into the intravascular. So again, like I said, they reach equilibrium and do not contribute in the Starling equation. You can add it, so I put it in there. If you do add osmotic pressure, that can help. So if you put extra osmolarity within the capillary space or in the intravascular space, then you will actually be able to pull it in, but otherwise it's not going to contribute. So let's look at fluid categories and fluid types. I think it's important to understand the terminology. So let's look at the definition. So resuscitative fluid. So that's fluid used to correct intravascular volume deficit or acute hypovolemia. There's maintenance fluid, so that's fluid given to provide the patient's daily basal requirements of water and electrolytes. And then there's replacement fluid, so that's described as ones where you're having deficits that you can't just compensate by oral intake. And people often confuse maintenance fluids with replacement fluids. Replacement fluids would be like if you had a drain or a high output fistula or significant fevers or significant polyuria, you may not be able to replace that fluid just with oral intake, and you may have to give IV fluids to help out with replacing those that are going in versus just maintenance fluids, which is going to be what's just the body evaporates with breathing or through their skin. In terms of giving fluid, there's a fluid bolus, which is a rapid fluid infusion to correct hypotension and hypovolemia. There's a fluid challenge, which is just about 100 to 200 mLs over about 5 to 10 minutes, and then reassessing the hemodynamic status. So I gave this fluid, did it help? Those are going to be the two differences whenever you're going through it. So whenever we're dealing with resuscitation, we're going to be talking about either a fluid bolus or a fluid challenge. Resuscitation fluid, we'll talk about that. It's important to understand what the purpose of resuscitative fluid is. So shock. Shock is a state of insufficient blood flow to the tissues of the body as a result of problems with the circulatory system. So something that's not allowing you to have good blood flow, good oxygen delivery. There's 4 different types of shock that we talk about. There's distributive shock, hypovolemic shock, cardiogenic shock, and obstructive shock. When we're talking about fluid resuscitation and shock, you're not really going to be using fluid resuscitation in all of these. So cardiogenic shock, typically they're actually on the wet side and they don't need any more fluid resuscitation. And obstructive shock, fluid isn't necessarily going to help because it's an obstruction. So if you have a massive PE, giving more and more fluid is not going to help from a blood pressure standpoint. So you're not necessarily giving fluid resuscitation in obstructive shock. That does leave distributive shock and hypovolemic shock where there is a role for fluid resuscitation. All of fluid resuscitation is based on the oxygen delivery equation, which is the most important equation in critical care. So oxygen delivery is just oxygen concentration times flow. Oxygen concentration is 1.34 times hemoglobin times saturation plus 0.003 times the partial pressure of oxygen. And then you just multiply that by cardiac output. So you have your concentration and then you have your flow with the cardiac output, and that gives you oxygen delivery. So this is the full equation. And the way to break it down is just saying that in order to deliver oxygen, you need a cardiac output, you need hemoglobin, and you need oxygen on that hemoglobin with a saturation. This means that if you need to improve oxygen delivery, you need to improve cardiac output, improve hemoglobin, or improve saturation. Now, hemoglobin and oxygen saturation are easy to identify and improve. If you're hypoxic, then add more oxygen. If you're anemic, then add more hemoglobin. But cardiac output can kind of be difficult to maneuver in terms of trying to optimize someone's cardiac output for oxygen delivery. This is the Starling curve mixed with the Guyton venous return curve. But if you look at the red curve, you have the Starling curve. And what that says on that ascending part of the curve is that as you give more fluid, you then increase their cardiac output. You're improving venous return. The more venous return, the more stretch on the ventricles, the more the stroke volume, the more the cardiac output, up until you get to a point. And then at that point, it starts to plateau and even have a descending limb where you start actually getting worse the more and more fluid that you get. So whenever you're giving resuscitative fluids, you have to say, I think that I am on the ascending limb of the Starling curve. I think that if I give more fluids, I will improve venous return, which will improve the stretch, which will improve the stroke volume, improving cardiac output and oxygen delivery. Resuscitative fluids, there's isotonic fluids, so that would be ones that will increase total extracellular volume. There's colloids, which will increase intravascular volume, and then there's hypertonic fluids, which will increase intravascular volume. So you have to ask what kind of disease process you're dealing with. Now, if you're dealing with somebody that's hypovolemic or dehydrated, then it would make sense that you would increase total extracellular volume. If you have somebody that's in distributive shock and they're vasodilated in their third spacing, you actually are looking more to just increase intravascular volume. So just keep that in mind on how the studies look to say like how things are going to do on whether or not you're going to be giving intravascular volume versus just total extracellular volume. Now, isotonic is the fluid of choice whenever we're dealing with both hypovolemic and distributive shock, except in the case of like hemorrhagic shock, where you just want to be giving blood products. But in isotonic fluids, they're very cheap, they're very available, and so that does tend to be the fluid of choice, although you can have arguments for the other ones that I'll talk about. Under isotonic fluids, we typically either use normal saline, lactated ringer, or a balanced crystalloid like Normasol or Plasmolite. Under hypertonic fluids, we have 3% saline. There's half, they're 4.2% sodium bicarb, which is a amp of bicarb is 8.4% sodium bicarb, so it would be about half that concentration. And then there's 25% albumin, which is hyperoncotic, but still would kind of fit under the hypertonic fluid standpoint. And then under colloids, we have both the 5% and the 25%. So again, when we're dealing with resuscitative fluids should always be done in boluses because you're looking for a response. So there's no like maintenance, constant drips when dealing with resuscitative fluids. If you think they need to be resuscitated, as in they are in shock, then it needs to be done in a bolus quickly to help reverse this shock. So it should be done under a pressure bag under a short amount of time so you can see these results. If someone is getting a pressure bag of fluid, you want to say, are they improving? Are they having an improvement in blood pressure, a reduction in heart rate? Something that says that they're on the ascending limb of the Starling curve. If they're on the descending limb or on the plateau part of the Starling curve, then they're not going to be responsive to this fluid. So if you give somebody a fluid bolus and nothing happens, or even they may get worse, then you need to say, hey, I don't think that they're on the ascending limb anymore. I think that they're starting to get to the plateau or descending limb. Looking at the different fluids, things that I want to point out is if you look under normal, this is what the normal body is in terms of their electrolytes. Normal saline is obviously not normal. It has a little bit more sodium than you would expect, 154 versus 140, which is not that big of a difference. But if you look under chloride, it's 154 versus 102. It's just a huge amount more of chloride than what you would expect. Whereas lactated ringer and then Normosul and Plasmolite are much more what we call the balanced ones. They're going to be closer to what the patient has. Now, the one thing I will remark under lactated ringer is that it has a sodium of 130. So it does trend towards an almost hypotonic solution. And if you look at the osmolarity, it's 274 versus the other ones, which are much higher. So if you're going to be doing large volume resuscitation, over time, having that more hypotonic fluid may not be beneficial. You may get more benefit from like a Normosul or a Plasmolite that's going to be closer to 295, and it's going to have a more normal sodium whenever you're dealing with it. Let's look at hypertonic solutions. So it makes sense that if hypertonic fluids stay intravascular, that in distributive shock, that if you can keep that intravascular volume, you're gonna be able to keep that blood pressure up higher. So if you look here, it says data suggests that hypertonic fluid in sepsis may have beneficial effects. Another one that came out in 2013 that says that there appears to be some justification for the use of hypertonic saline in septic shock in terms of suggested mortality benefit. Multiple studies have showed the same thing. The big one that came out was 2018, looking at the bicarb ICU trial. And this was using hypertonic bicarb. So in this, they used a 4.2% solution of sodium bicarb. And they would give 125 to 250 ml boluses with a max of about a liter within 24 hours after inclusion. And what they found was patients with severe metabolic acidosis and an AKI, they actually improved mortality. And they actually put this recommendation in the Surviving Sepsis Guidelines to say that in acidotic patients with AKI, they do recommend bicarb. And then specifically in this trial, it was hypertonic bicarb. It does increase sodium slightly, does decrease potassium and decrease calcium just from it being bicarb. They're very minimal. Anytime that I've ever used it and I've gotten serial labs, I've had minimal to no enough changes to make any sort of replacement or changes in management. 2018, there was the SWIPE trial. This looked at small volume resuscitation. So this one used 20% albumin. Typically in the US, we have 25% albumin, but either way, it's this hyperoncotic albumin that'll help keep things intravascular. And what they found was that by using that 20% albumin, it decreased the resuscitative fluid requirements. You didn't have to give as much because it wasn't leaking out into the interstitial space. It was staying intravascular, so you didn't have to give as much volume. There's also a meta-analysis that looked at 5% albumin versus regular saline alone in large volume resuscitation. And what they found was that there was actually a mortality benefit whenever they looked at it, which was interesting that they were able to show that when typically other ones have not been able to show. Next, I want to talk about, which is monitoring resuscitation. Monitoring resuscitation says, hey, I want to know whenever I've given enough fluid, because if you don't give enough fluid, then they remain in shock. But if you give too much fluid, you're going to end up with all the complications of volume overload. So you want to give the exact right amount of fluid that will get them resuscitated out of shock, but not volume overloaded. So what can you do to monitor your resuscitative process and make sure you're getting it at the place that you need to be? So there's assessing volume responsiveness, and then other people have looked at serial lactics to say, okay, I must be improving oxygen delivery because my lactic acid's improving. We're gonna look at volume responsiveness first on when to say when. And again, we're talking about the Starling curve. So we want to say, okay, I want to make some sort of evaluation to say, am I still on the ascending limb? If I'm not on the ascending limb, and if I'm on the plateau or descending limb, I need to stop doing resuscitative fluids. I'm already past the resuscitative phase whenever it comes to fluids. One of the most common ones that people talk about would be the passive leg raise. And that's where people will then put their legs and they will then get about a 250 ml bolus of blood back to their heart. And they would assess to see how the heart would respond to that extra fluid. I think that this is a good method. You're not adding extra fluid in. Things to watch out for is in the original trial, they actually had a bed where the foot would go up, so it truly was passive. If you grab someone's legs and put them up in the air, if you grab them too hard or if they're sensitive or if it causes pain, that could make their blood pressure go up. simply due to pain or being uncomfortable as opposed to being responsive to that change in volume. You can also use the IVC. I think the IVC is important. There's a lot of gray area if it's in the more normal range. So if your IVC is completely collapsed and you can't really see it, then obviously they would probably be more likely to be volume responsive. If your IVC is dilated and not variable at all, they're probably not going to be volume responsive. Anything else in between can make it a little bit more difficult. There's a lot of studies that will tell you different results on looking at the percentage of variability and different ways of looking at it. But I think it's a really important step is just looking at the IVC, making an assessment that can really help kind of lean you in one direction or the other to say, okay, this IVC is really big, it's pulsatile, we do not need to give any more fluid, or the IVC is still small, still collapsing. I think that they could actually use some more volume. Another thing to look at is pulse pressure variation. So every time we breathe, we'll actually partially collapse our IVC and our SVC, and this will change the amount of venous return going to our heart. And so it will change our stroke volume. And so you will see some variability in everybody for the most part whenever you look at their A-line or you look in their pulse pressure variation. And if you look at the area under the curve of their pulse, then that's actually what their stroke volume is. And so you'll see differences in that stroke volume or that pulse pressure variation, the differences there. If you have somebody that's volume overloaded, is that you now no longer can collapse their SVC and their IVC because there's so much fluid in there and you'll lose that variability. So you can actually use pulse pressure variability to decide whether or not they would be fluid responsive. We use a machine. The FlowTrack or the Visualeo uses this same method where they look at the area under the curve of the pulse through like an arterial line, and they would look to see how much stroke volume variation there are. For that particular device, if you have a stroke volume variation of less than 13%, then they feel like they would not be volume responsive. And if it's greater than 13%, then they feel like they would be volume responsive. Again, that doesn't mean that they need fluids if it's greater than 13%. It just means that if you wanted to give them fluids, they would probably be volume responsive. So again, this is all has to do with the Starling curve and saying, okay, I think I'm still on the ascending limb of the Starling curve. I think they need more fluids because I'm still trying to resuscitate them. I want to see if they're going to be responsive to the fluid that I give them. Next, we're going to move to just maintenance fluids and understanding what you're ordering. So maintenance fluids are used to replace insensible losses. So whenever we breathe, it's humidified. So you'll see that that will lose some throughout the day. We also talk about maintenance fluids for like glucose administration if someone is NPO. We'll talk about what kind of fluid that we're going to give them. Now, keep in mind, insensible losses are hypotonic. So whenever you would give somebody maintenance fluid, it should also be hypotonic. So if you need to have something that would be like half normal saline, something, because if you're truly using it just for maintenance fluids, it should be hypotonic in nature. Let's look at a maintenance order. So let's say you decided to order D5 half normal saline because you wanted the dextrose, you wanted the half normal saline because it's hypotonic, and you decided to do it at a rate of 125 milliliters an hour. You decide they need glucose, they need hydration, they're NPO. How much fluid is that in 24 hours? Well, 125 milliliters over 24 hours is 3 liters of fluid. And if you look at that in glucose in 24 hours, it's 5 grams and 100 grams of water or 100 mLs of water. So it's 50 grams per liter, and you're giving them 3 liters. You're giving them 150 grams of glucose. Keep in mind, you're giving them about 1 12-ounce can of Mountain Dew with every liter of fluid. Is that worth 3 liters of fluid? So you're giving them 7 pounds of water, you're giving them 13.5 grams of salt, which is recommended less than 5 grams, and you're giving them 3 Mountain Dews worth of glucose. So is it worth 3 Mountain Dews worth of glucose for all that extra side effects of all the salt and all the soda and all the water that you're giving them through there? Why do we need this maintenance fluid? So we say, okay, if somebody is sweating, that's going to end up losing fluids through there, and that can definitely happen. And we also have insensible fluids from like the skin, the respiratory tract. When we look at the amount of fluid that it is, we lose about 400 milliliters in an adult through the skin, and we lose about 400 milliliters a day through the respiratory tract in an unstressed adult. So obviously, if you have a critically ill patient, you may lose a little bit more, but overall, it's about 800 mLs a day of insensible losses. We also have some insensible gains. So we make about 400 milliliters a day of water as a byproduct through the electron transport chain. So we lose about 400 milliliters a day in a normal unstressed human. If you have somebody that's obviously critically ill in the ICU, it may be a little bit more than that, but we're not talking about 2-3 liters of fluid of maintenance fluid. You may have other losses that would fall under replacement fluid, like drains or fistulas or things like that. But in terms of just maintenance fluid, you're talking about 400 milliliters a day, and then a little bit more depending on how sick the patient is. That ends up being about 17 milliliters an hour. So not very much fluid versus typically people are putting 50, 75, 125 milliliters an hour through their maintenance fluid. Next, we're going to talk about replacement fluid. So again, this is going to be whenever you have some sort of larger output and making sure you replace that if it can't be replaced orally. So it's needed for high output drains, high output fistulas, significant prolonged fever, polyuria, you'd want to be able to do that, severe diarrhea. These are all what would be called replacement fluid. Now, typically, these are all going to be more in the isotonic area. So if you're going to be doing replacement fluids for these losses, you do want to use isotonic fluid, but it can vary depending on what you're losing. Next, we're going to be talking about fluid overload and the complications related to fluid overload. So this is somebody that got like over resuscitated, they got too much volume, and now you're dealing with the complications of all the extra volume that they got. Let's look at fluid prescriptions in the hospital. So resuscitative fluids, it should be isotonic, it should be boluses, typically about 250 to 500 mLs at a time to make sure you're assessing for changes in hemodynamics while you're doing it. And your endpoint would be, as soon as they're not responsive, you should not do it anymore. Maintenance fluid is going to be more hypotonic. It can be continuous, but it's not going to be very much. You're looking at 500 to a liter a day, and then you should end it if they have adequate PO intake. And then replacement fluid should be isotonic. It can be continuous, and then it can just vary on the losses depending on how much output they're having, and then what disease process is going on. And so whenever those losses are reversed, whenever the disease process is fixed, then you would want to stop those. Let's look at fluid balance and overload. So definition-wise, fluid balance is the sum of intakes and outputs. Cumulative fluid balance is going to be the sum of the fluid accumulation over a set period of time. So over an ICU stay or over a hospital stay. Fluid creep, so the obligate ends or fluid the patient receives that's not for fluid resuscitation. That's really important to understand, is just understanding that while you may order a liter of fluid, they're also getting antibiotics and electrolytes and different things that are going to be going through the IV that will add up over time. Is fluid overload harmful? What does the physiology say? If we look at this is a famous picture, but it looks at all the different complications of fluid overload, and we can look at them all individually, but you can see the list that goes on for people that are fluid overloaded. So under respiratory, you get pulmonary edema, pleural effusions, decreased chest wall elastance, drop in PF ratio, increase in carbon dioxide, increased work of breathing, myocardial edema, increase in your CVP and wedge pressure, decreased venous return, which is going to worsen your cardiac output. Pericardial effusions can occur. In the GI side, you can get ascites, gut edema, increased intra-abdominal pressure that can lead to like abdominal compartment syndrome, even increased bacterial translocation. On the renal side, you can get that interstitial edema that leads to AKI. You get increased renal venous pressure, you get decreased renal blood flow, salt and water retention. All of these lead to complications. And the abdominal wall, you can have increased edema, poor wound healing if you're a surgical patient, increase in pressure ulcers, decreased abdominal compliance. On the liver side of things, you can have hepatic congestion, impaired synthetic function, hepatic compartment syndrome, and then even in this central nervous system, you can get cerebral edema, impaired cognition, delirium increases with fluid overload, increased ICP. So a whole lot of complications related to fluid overload. Fluid overload, by the traditional definition, would just be an increase in admission weight by 10%. Or clinical signs would be new pitting edema, crackles, or anasarca as compared with admission. So either based on just your weights or based on clinical signs. There's a concept called the ROSE concept. And so this deals with resuscitation and then optimization, stabilization, and evacuation. So the idea is that when you're resuscitating somebody in shock, this should happen over minutes. And then you have this optimization. This is where you have somebody where you're not necessarily still giving all that resuscitative fluid. You're just trying to stabilize them from a shock standpoint. And then as you're in that stabilization phase, you're kind of just letting things settle out. And then you need to be in the evacuation stage, which is like the de-resuscitation phase, where you start needing to get things back off of them. And that's going to take place over days to weeks. So if you look at this picture, on the top is cumulative fluid balance and on the bottom is organ failure. So in the R, or resuscitative stage, you have organ failure due to them being in shock, and you start giving them resuscitative fluid. So your fluid balance goes positive because you're giving them fluid, and your organ failure gets better because you're in that resuscitative phase. And then once you're out of that resuscitative phase, you're in the optimization phase. And so you shouldn't be continuing to give lots and lots of fluid during that stage. And this is in the hours to days after the shock, where you're just saying, okay, they're out of that resuscitative stage. They're not in that fluid responsive stage. I'm still just trying to optimize them from a shock standpoint. So you can see that there's no change in the cumulative fluid balance, but you are going to start seeing that if you don't start trying to stabilize them and trying to get that fluid back off of them, you can actually get a second hit of organ failure. And that second hit of organ failure is actually related to the fluid overload. So if you see somebody getting worse on day 3, day 4, day 5, it's not because they're having continued sepsis or continued shock from their initial hit, is that it may actually just be complications related to all the fluid overload that's happening and the complications from it. What is particularly susceptible is the kidney, and that's because it's surrounded by Gerota's fascia. So it has this layer of fascia around it, so it can't grow. Your liver can get bigger, your intestines can get edematous, but your kidney can't really grow because it's surrounded by that layer of fascia. And so it puts that pressure on it. And you get this increased interstitial pressure, you compress your tubules, you end up dropping your GFR, you're getting an acute kidney injury because it's basically crushing the kidney up against the fascia that prevents it from growing. Looking at how much we've been aware of positive fluid balance, from 2000 to 2009, we had about 253 papers on positive fluid balance and the complications of positive fluid balance with resuscitation. And then over the next 10 years, there were 608 papers. So you're talking about a 240% increase in the amount of papers just over that 10-year time period. So you can see that the stress that people put on realizing is that when we're resuscitating people, is that oftentimes we're over resuscitating them and getting complications from a positive fluid balance. And that's what the data shows as well. So in this systematic review, it said if you had a positive fluid balance starting from day 2, so you're now over the resuscitative phase, which should really only occur in the first hours, but after the first 24 hours, if you had a positive fluid balance from day 2 to when you got discharged from the ICU, they had a much higher mortality than if they didn't. Surgery-wise, so people says, what about surgical patients are different? Is there anything in the perioperative phase? So from 1990 to 1999, there were 8 trials. And then over the next 8 years, there were 31 trials. So again, that's almost a 400% increase looking at perioperative cumulative fluid balance. And it shows the same thing. So in this 2002 study, it showed that when they did fluid restrictive versus fluid liberal, that the fluid restricted strategy led to shorter hospital stays, faster recovery of GI function, decreased post-op complications. And then in 2005, same study, they used fluid restrictive of 1.4 liters versus fluid liberal of about 3.9. In the fluid restrictive, they had shorter hospital stays, faster recovery of GI function, decreased post-op complications. So by having less volume in them, that fluid overload complications, they just did significantly better. Fluid creep. So like I said before, this is all those fluids that you didn't anticipate that you'd be given. So vancomycin can be in 500, even liter bags. Sodium phos or potassium phos through an IV can be up to a liter of fluid. Potassium replacement, Zosyn, all sorts of medications. Anytime you're giving vasopressors or inotropes, vasopressors, if they're not concentrated, can be 100, 200 cc's an hour, depending on how sick the person is. And that's going to add up over time. So they're just unaccounted for fluids whenever you're dealing with fluid resuscitation. So you may say, I only gave them 2 liters. There's no way they're volume overloaded. And when you look on their eyes and nose, they actually got 6 liters of fluid. In this study, they actually showed that the patients averaged getting about 6 liters of fluid, and that 3.5 liters were just related to medication. So 63% of the volume that they got was not due to any fluids that were given by somebody. They were all just medication diluents that were given. There's another one that looked at surgery and trauma patients. So they said, let's decrease maintenance fluids. So like I said before, you're talking about those insensible losses and making sure you're recovering them. And they looked at fluid restrictive, which would be 30 mLs per hour, versus fluid liberal, which would be 125 to 150 milliliters an hour. And what they found was the ones that were fluid restrictive had shorter ICU days, fewer ventilator days. So let's limit the patient's input. Stop maintenance fluids. Typically, patients in the ICU do not need maintenance fluids. They're getting plenty of fluid from different IV things that are being put into them. Make sure you track unaccounted fluids or that fluid creep. Concentrate medications when possible. That's going to be less ends, and just be aware of that fluid creep. I know people are going to be apprehensive to diuresis or less fluid, so things to look at. There's actually an equation now within medical literature that's called a dilutional creatinine clearance. And the idea is that if you give somebody a whole bunch of fluid, 4 to 5 liters of fluid, and their hemoglobin goes from 12 to 8, we automatically say, okay, that's just dilutional. They're not actually bleeding. We just gave them a lot of fluid. The same thing happens for creatinine. And whenever you make somebody lose a lot of fluid, as they start having a lot of deresuscitation or volume out, is that their creatinine may drift back up, but it's not because you're causing kidney injury with that. You're just actually showing what the actual kidney function is because you've diluted it out with all that fluid. If you look at these studies, they look at the fluid balance and they look at the serum creatinine, and they'll actually show that if you have a very high fluid balance is that you'll have a creatinine that you're not really showing. So they have the regular serum creatinine, and then they'll actually have the adjusted serum creatinine where you can see that there's slight differences. So for example, you would have somebody that would look like their creatinine was only like 1.8 whenever it was actually closer to 2 just from that. And so if you look here in this visual, you can look at what the actual creatinine was versus the corrected creatinine secondary to the fluid balance. And what they found was that people were actually getting the delayed diagnosis in renal failure because it was being hidden, that increase in creatinine was being hidden behind all that excess fluid. So if you look here, the daily volumes you look at the total fluid accumulation between them, and you're talking about very, very high amounts of fluid, like 11 liters versus 3 liters. And the ones that had late recognition just had the super high volume, had those 11 liters versus the 3 liters. And so all that kidney injury, all those complications that happened to the kidney were being hidden by all that extra fluid. And so they weren't being recognized. And that led to increase in kidney injury. And it also led to an increase in dialysis needs just because they weren't finding it until it was much later along. A higher cumulative fluid balance at 72 hours of ICU admission was independently associated with hospital mortality, regardless of AKI or CKD. So just having too much fluid, a high cumulative fluid balance led to worse outcomes. Another argument I hear is that people are extravascularly volume overloaded but intravascularly deplete, so we can't diurese them. We should give them more fluid, which doesn't make any sense to me. What it does mean is even if that were true and you had a bunch of fluid extravascular that's not intravascularly, you would want to be doing things that are going to pull that intravascular volume intravascularly. It would not be giving them more isotonic fluid. It would be finding ways of getting that extravascular volume intravascular. The only way you could really be extravascularly volume overloaded but intravascularly deplete would be if your oncotic pressure was so low that you would be spontaneously third spacing. So cirrhotics, really bad cirrhotics, will actually be intravascularly deplete, extravascularly volume overloaded. And that's all due to just a very, very low oncotic pressure. You're below that Gibbs donor effect. You're below that kind of 2.5 grams per deciliter deciliter of albumin. In that situation, the answer isn't give them fluid. The answer is replace their oncotic pressure by giving them an oncotic pressure that's going to pull in all that intravascular fluid. And so that's why we see whenever we have these sick cirrhotic patients, we end up giving them albumin. And that's because we know that having that albumin in there is going to increase that intravascular volume. So same thing if you have a septic shock patient. If they're post-shock, if they're in that post-resuscitative phase and they have a low oncotic pressure, you're not going to be able to mobilize that fluid. So if they have an albumin of 2, 2.5 or less, then you really should give them some replacement oncotic pressure in order to really get that extravascular fluid back intravascularly. So like I said before, if you have a low colloid oncotic pressure, which means albumin, then you ideally want to replace that oncotic pressure. 75% of your oncotic pressure is albumin. That's why we end up replacing with albumin. And then again, if you drop below 2, 2.5, that's when you're going to start getting that edema from spontaneous third spacing. Are we seeing a shift in treatment? Are people doing better over these last years? If you look at Rivers, the trial, the early goal-directed therapy trial in 2001, over 72 hours, they gave 13 liters of fluid. And if you look in 2014, what they gave was, in Europe, they gave about 7 to 8 liters of fluid. In Australia and New Zealand, they gave about 8 to 9 liters of fluid. And then in the US, they gave anywhere from probably like 8 to 11 liters of fluid. So we did the worst out of all the groups in Turtle, but I think we're in the right direction that we're giving significantly less fluid than we gave back in 2001. Here's an example of a patient that I took care of. So 45-year-old male, hypertension, diabetes, hyperlipidemia, complaining of fever, chills, productive cough, was diagnosed with pneumonia and AFib with RVR. So they were tachycardic because they were in AFib with RVR. So the heart rate was anywhere from 150 to 180. Not hypotensive though, 100/66. So low, but not in shock. But because they were tachycardic, they were given normal saline at 100 mLs an hour. They're given a bolus of normal saline. They were given antibiotics, so Rocephin and azithromycin, both IV, given MAG IV. The day one, that was just the end of the initial day. Day one, they continued the normal saline. They started diltiazem drip, so that's more unaccounted for fluids. They got more normal saline, normal sol drips. They got more antibiotics. They got increased dazocin and vancomycin. They got blood because they started dropping their hemoglobin from all the volume they were being given. They then started getting more boluses. They got more antibiotics. And you can see that on day 2, they actually got 9 liters of fluid with minimal output. And then on day 3, they went back to being given continuous fluid. They started an amnio drip. They started more antibiotics. And again, they got about 6 liters of fluid in at that point. If you look at the x-ray on day 0 compared to day 3, you can see that there's just a huge amount of volume overload that occurred over that 3-day period. So at the end of day 3, they had gotten 21 liters of fluid. They were positive 19 liters. And we had to cannulate them for ECMO, for VV ECMO, because they were so hypoxic from all the fluid that was being given to them while they were on the floor. And then whenever we got the ICU consult came with, and they also need an ECMO consult. Let's just look. They got 1.5 liters on day 0, 3.7 or almost 4 liters on day 1, 9.5 liters on day 2. They got 6.5 liters on day 3. Let's break this down. They got 3.3 pounds of fluid on day 0, 7.7 pounds on day 1, 21 pounds of fluid on day 3, and 14 pounds of fluid on day 3. And so if you look, that is an average of 6.5 liters of fluid a day. And they were given 46 pounds of fluid over that 3.5 day period. That averages about 14 pounds a day of fluid. So if you could imagine just taking on 14 pounds of fluid every day for 3.5 days, and then realizing what it's going to do to your breathing, how you're going to be able to kind of keep trying to compensate for you being sick. Let's look at the fluid content, so sodium overload. They were given mainly normal saline. So 1 gram of salt, of sodium chloride, is about 390 milligrams of sodium. 1 tablespoon of salt is about 6 grams of salt, is 2.4 milligrams of sodium, which is about 104 milliequivalents of sodium. So 154 milliequivalents of sodium, which is what's found in a liter of normal saline, is about 9 grams of salt. That is 2 times the daily recommended salt intake or sodium intake, just to keep that in mind. So how many Lay's potato chip bags, the 1 ounce Lay's potato chip bags, do you think you would have to eat to equal the amount of salt in 1 liter of normal saline? It ends up being about 22 bags of 1 ounce Lay's chips. So that's how many you would have to eat in order to get the same sodium content you get from a 1 liter fluid bolus. So if you've ever given somebody a liter bolus of normal saline, you're giving them the salt equivalent of 22 bags of Lay's chips. And then if you try to sit down and think, how many could I eat before I felt like that was just way too much salt for my system? And then what I've had people do is after they've given 2, 3, 4 liters of normal saline, the patient will say, I am really thirsty. And they'll say, oh, they must be still dehydrated, and they'll give them 2 or 3 more bags of normal saline on top of it, understanding that that is just so much salt that you're putting into that person. So let's look at what his fluid prescription was from a salt standpoint. So on day 0, he got 33 bags of chips. On day 1, he got 77 bags of chips. On day 2, he got 209 bags of chips. On day 3, 143 bags of chips. He averaged he got a total of 189 grams of salt, or 462 bags of chips. You could see how he ended up getting volume overloaded and having to go on VV ECMO. Let's also look at chloride overload. So there's a whole bunch of chloride in normal saline that we talked about. The average is 100 for a person, and normal saline has 154 milliequivalents. So is that harmful to people? So if you look, the patients that end up having a chloride liberal fluid, which would be like normal saline, are more likely to have kidney injury in critically ill patients. Hyperchloremia is associated with hospital mortality in septic shock patients. Saline should not be your first choice in crystalloid resuscitation. Hyperchloremia is associated with mortality in critically ill patients. Hyperchloremia after non-cardiac surgery is independently associated with increased morbidity and mortality. You should learn the strong ion difference. I think this is a great way to understand how bad excess chloride is for the body, how it can lead to acidosis, how it can lead to acute kidney injury and increased mortality. I have another lecture that talks about strong ion difference and how we can look at acid base and how normal saline affects acid base within the body. This patient started out with a bicarb of 16 and a chloride of 100 with an anion gap of 14. We can then look at on day 3, their chloride had jumped from 100 to 116 and their bicarb was down to 7 because there was so much chloride in the body that the body's response to this was just to stop making bicarb. So they had the same anion gap, but their bicarb was so much more because they'd gotten so much chloride from so much normal saline. And they were severely acidotic. So they had an anion gap metabolic acidosis, but they also had a severe non-anion gap metabolic acidosis from all the normal saline. At the end of day 3, they'd gotten 46 pounds of fluid, 189 grams of salt, and their bicarb had changed from 16 to 7. I don't think that we as a practice did anything to help this person. In fact, everything we were doing was making him worse and worse until we had to cannulate him for VV ECMO. And once we cannulated him for VV ECMO and stabilized him, he only needed to be cannulated for about 2.5 to 3 days. And literally all that was done was just started him on diuretics, stress dose steroids, diuretics, and getting that 46 pounds of fluid back off of him. And then he was able to start being able to breathe again, oxygenating better, ventilating better. We're able to get him decannulated. So if you look how his bicarb continued to drop and drop and drop because of all the chloride that he was being given. So after 21 liters of fluid, he was down to a bicarb of 7. And you can see that huge change in his x-ray from all that extra volume. He had a pH of 7.12, a PaO2 of 52, a CO2 of 55, a bicarb of 8, and a base deficit of -15 whenever we went to cannulate him. So again, looking at these options, Normasol and Plasma-Lyte, they have the best difference between cations and anions, or the best difference between sodium and chloride, definitely compared to normal saline. Lactated ringer is very close. Again, I like lactated ringer a lot. If I'm going to be doing large volume resuscitation, I typically pick Normasol just because it has a sodium that's 140 as opposed to a sodium that's 130. If you look at all the different types of fluids and then how it affects your acid-base status, normal saline causes it to be a lot of acidotic. Same thing with half normal, quarter normal, D5W. Lactated ringer is fairly neutral. Normasol is slightly alkalotic. I like it just because everything that is any medication diluent is either going to be normal saline or D5W, which trends you towards acidosis. So I feel like Normasol just kind of brings you back to center. Albumin is going to be acidotic, 25% albumin acidotic, hypertonic saline acidotic. And then obviously if you were going to do a bicarb drip, it would be alkalotic just because it's just sodium and bicarb. Last, we're going to be talking about deresuscitation or fluid removal. So deresuscitation, be aware of the patient's total intake of the day. So I have a lot of times that people will tell me, goal is to make 2 liters of urine. And I was like, well, that's great. But if we give them 4 liters of fluid, then we did not deresuscitate them. You need to be aware of how much you're putting in, and you want to be talking about net negatives. I want them to be net negative 1 to 2 liters or net negative 2 to 3 liters. And that way you're aware of how much fluid they're getting on the intake side. And just feel comfortable with diuresing patients if they're stable. As soon as somebody is on a stable or decreasing amount of pressors, they actually recommend go ahead and start deresuscitating. If the patient has a positive fluid balance, if you've evaluated them and they show signs of volume overload, you can start diuresing them on pressors, intubated, however you want to do. As long as they're in a stable or decreasing manner, they're going to tolerate it really well. Have a goal in mind, and at the end of the hospital stay, ideally you want to return them to their admission weight if they came in euvolemic at the beginning. So what to give? Diuretics obviously is going to be the big thing to give. And like I said, there's a difference between diuresing somebody and giving somebody a diuretic. If you give somebody 20 milligrams of furosemide and they pee 2 liters, but you gave them 4 liters, that's not really diuresing them. Diuresing them, and the definition that we refer to, would be having more out than in. So whenever you want to give diuretics to the point that you have more output than input. So if they're having a kidney injury and they're just not making a lot of urine output, you could always just try to do everything you can to reduce input. So limit the amount of fluid. Anything that's IV, you can change to PO. Anything that's not concentrated, that you can concentrate. Anything that you can get rid of that's going to reduce that intake. Or when to give it. So early diuretic use and mortality in critically ill patients with vasopressor support. Hospital mortality was significantly lower in the diuretic use group. So in critically ill patients on vasopressors, the use of diuretics actually reduced mortality. So as soon as that patient is on a stable or decreasing amount of vasopressors, you can feel comfortable go ahead and starting the deresuscitative process. The next thing I want to talk about is diuresis versus natriuresis. So diuresis would be the removal of water, whereas natriuresis would be kind of the removal of salt and water. And it does make a difference. So if you give somebody a diuretic, what's really happening here is that you're kind of losing fluid from the entire total body water, as you can see from above, versus if you were doing natriuresis and you're removing a more isotonic fluid, you're actually just removing it from the extracellular space. And that's going to go a long way to help reduce interstitial edema if that's what you're trying to get rid of. So making sure that when you're giving a diuretic that you're also getting some natriuresis, looking at the sodium content, making sure that you have more of an isotonic content to the urine output will allow you to get rid of that edema faster. Like I said before, when dealing with fluid balance, if you have a high fluid balance from day 2 on in the ICU, they have an increased risk of mortality and severe sepsis and septic shock. So once you're past day 1, you should either be fluid even or start the deresuscitative process. So putting it all together, Optimize preload, resuscitative fluid, understanding that when you're giving fluids, you're saying, I think they're in shock. I think they need to be resuscitated. I'm giving them fluid to get them higher up on the Starling curve because that will improve stroke volume and improve cardiac output and oxygen delivery. If you don't think that they need fluid, then you don't need to just give it because you think they're on the ascending limb. But any time that you're giving fluid in the resuscitative part of fluid is that you're saying, I think that they need fluid and I think that they, in the resuscitative process, that this will help improve. And you want to look for the response. Are they getting an improvement in blood pressure? Are they getting a decrease in heart rate? If they're not responding to it, don't just keep giving it because it may mean there's something else going on. Make sure you monitor the resuscitation, when to say when. Monitoring either with a passive leg raise or IVC or pulse pressure variation, stroke volume variation, something that says that you're saying, look, I took a closer look. I think they need fluids and I think they would be volume responsive as opposed to just giving fluid and fluid and fluid and fluid. Fluid overloaded increases mortality. Be aware of what type of fluid you give, how you give it, why you're giving the fluids. All of these things should be taken into account anytime that they're ordered. Thank you very much.